Hello?
So no one's going to just be able to reply back to you, so maybe if someone could type into the chat if people can hear us speaking on the webinar.
I'll do it now. Morning everybody, it's Maureen Flynn speaking. Welcome to QI Talk Time, our regular lunchtime catch-up on all things quality improvement on a Tuesday. Thank you all for joining us, and thank you for bearing with us. We've one or two little technical problems that we're working out. So the first thing to say is, if you could send us a message in the chat box to let us know, can you hear us? That would be fantastic. And we're just sending you the dial-in numbers into the chat box if you can't hear, for you to phone in and put in your password. So I'd really like to welcome our three colleagues, Siobhan Young, Anne Klein and Una Healy. They're here to share with us all their learning in terms of using after-action reviews. So welcome, ladies, and thank you so much. So in the session today, we're going to learn about after-action reviews, hear first-hand experiences using this approach, and have an opportunity to ask questions through the chat box. So Siobhan, Anya and Una have prepared a presentation, and they're going to talk us through the presentation, and we will gather the feedback as we're going through the presentation and come together for a chat towards the end. Anybody who has any burning question as we're going along, be sure and put it in the chat box and we'll stop as we go. So Siobhan works with HSE Quality, Risk and Safety in the Quality Assurance and Verification Division. Anya is Quality and Safety Lead in CHO Dublin North City and County. And Una is working in Our Lady of Lourdes Hospital in Drogheda and St. James. St. James, sorry. I'm looking at the history, Una. I'm looking at the history rather than the current. My apologies. So keep the questions and chat coming if you can. Thank you very much, and hopefully everybody has logged in by now. So over to you, Siobhan. Thank you.
Okay, thanks very much, Maureen. We're delighted to be here today to talk about after-action review. And as you said, we're going to hear service perspectives from Una and from Anya, but first of all, I'm going to just set the context, which is really the incident management framework. And then we'll have time for Q&A. So I'm sure people are aware at this stage that the incident management framework was launched last January 12 month, so January 2018. And it applies to all incidents that occur in publicly funded health and social care services provided in Ireland, including but not limited to hospital groups, community health organisations, national services and HSE funded care, so agencies funded under Section 38 and 39. So it has a very broad scope, and I suppose it's important to say that that's why it is a framework as opposed to prescriptive policy. And because it's a framework, there is flexibility to allow services to contextualise the approaches that are used. And we're going to be hearing about two applications of after-action review in a hospital setting and also in a community setting. But just to remind everybody, we have introduced after-action review as part of managing incidents, and even though we have introduced it as part of the incident management framework, we are encouraging people to use it in different ways. So we'll talk a bit more about that later. But just to remind everybody, incident management follows a 6-step process. The first step is supporting a safety culture. So, for example, supporting a culture where staff are supported and encouraged to report incidents so that we can learn from them to make services safer. The second step in the process is identification and the immediate actions required, and that includes those actions to support people involved in incidents. So both the person harmed, but also any staff that might have been directly involved in the incident. The third step is initial reporting and notification. The next step then is assessment and categorization, and I suppose it's this part of the decision-making process, the information gathering, that informs your decision what review approach to take. And after action review is one of the approaches set out in the framework. So we'll be drilling a bit underneath that and how that happens, how it's used as a review approach. And then step 6 is the improvement planning and monitoring. So closing the loop in terms of making services safer. So, as I said, there are lots of approaches in the incident management framework. The majority of them use systems analysis as their underlying methodology, so including the review panel approach that we spoke about 2 weeks ago, multidisciplinary team approach, the desktop approach. There are also 2 incident-specific tools. One was developed for falls and one for pressure ulcers, and then the aggregate review approach. The only approach that's set out in the framework that doesn't use systems analysis is after action review, or AAR, and that's what we're focusing on today. After action review has been described as arguably one of the most successful organisational learning methods yet devised. It was adapted for use in healthcare by University College Hospital London, and it was brought there by an Irish consultant, Professor Aidan Halligan, before his death. And Aidan Halligan and his colleagues have written a nice journal article called Life in the Slow Lane, Making Hospitals Safer Slowly but Surely. And that's available, there's a link there that you can access that article and read it. But it just talks about how they adapted after action review and how they recognise that it is appropriate for use in healthcare. After action review itself was developed initially in the military. And what is it? It is a structured, facilitated discussion of an event. And it helps, the process helps the individuals involved in the event to understand why the outcomes differed from that which was expected and what the learning can be identified. So basically, it brings people together and it hears multiple perspectives about the issue at hand. And it's a facilitated discussion to reflect on that. And it asks 4 questions. So it asks people what they expected to happen, and then it gives them an opportunity to outline what actually happened. And then the facilitator brings them through the difference between what they expected to happen and what actually happened, and what learning can be identified to assist improvement. And it is a way that all the participants, so the people in the room, can identify learning themselves. And then they can own the actions decided on to make the improvement. Now, as I said, we have introduced this as part of the incident management framework, but we are encouraging people to use it in other ways as well. And feedback has been that people are using it to review positive issues or incidents as well. So those times where there is a positive outcome. So you can review or debrief on situations like that to better understand factors that led to that. So it can be used after a training day, a meeting, whatever. It also can be used to review less serious incidents. And that's where it is used primarily, I suppose, as a review approach in the framework. So those incidents which don't reach the threshold of a Category 1 or a serious incident. And if it is, it can be used in certain circumstances after a serious or a Category 1 incident, but often as a debrief or as an initial look, a chance to bring the team together. And in those cases, it shouldn't be used as the primary source of evidence, where a comprehensive review, so a review panel approach or a review team approach is going to take place as well. So there is wide application for after-action review. Now, what is it that makes it so suitable for use in healthcare? Because it is a structured mechanism to allow teams to talk about incidents. And it involves listening to multiple perspectives. So it allows everybody in the room to give their perspective of the event. So there are multiple truths. No one is more important than the other. It focuses on learning and not blame. It can be led by anyone with good facilitation skills. And the beauty of it is it's easy to remember. There are 4 key questions. And as we said, it's applicable to almost any event. When it was adopted and adapted for use by the HSE, it began with Cornelia Stewart, the Assistant National Director in our office, talking to UCLH and learning from them. Herself and some colleagues also went across to London and had training provided by UCLH. They then established a co-design group and looked at how it might be developed and adapted for use in the HSE and HSE-funded services. The Royal College of Surgeons in Ireland was their Institute for Leadership was appointed to help design and deliver the course, and there are courses running in the RCSI approximately every month. And our office has developed support materials as well. And there's some of the materials that have been developed for people to support this use. And they're all available on the QABC Incident Management website there. So I'm going to hand over now to Una Healy, who has been using After Action Review in St. James's Hospital.
Thanks very much, Yvonne, and I think you set the context very widely there. So I suppose bringing this theory into practice, I'll speak a little bit about how we set about bringing it into the organisation, 1,000 beds, 4,000 staff, and how it was to bring it in and really have it embedded within the framework and the culture within the organisation, where it's a go-to tool and well supported and well facilitated. So when we started looking at this, we thought about, first of all, how do we start by selecting the team? So we strategized on that, and we thought it was really, I suppose, mindful of looking at where we sit within the Quality and Safety Division within the hospital. It was important that we didn't take on something that then we became the only go-to people. So we selected a team of co-facilitators who would all train together from different areas in the hospital, who would then be able to support and create a network across the organisation. And we felt that was the first underpinning key to making it successful for us. So we got an ED consultant who was a champion, and that was great because she helped bring her medical colleagues on board. We had an intensive care senior manager who again helped the critical care environment, and that was really good. We had a physiotherapist, so that brought in our AHP colleagues. We had somebody from the medical division in the organisation, myself in safety, and then we got learning and development facilitators so that any future learning then could be coordinated through that environment. So we felt we tapped into all key areas in the hospital that would help embedded quickly and broadly, and also be there as resources, because again, one team within quality and safety wouldn't be able to get this as part of the culture. And for us, that was the first thing that we got right, and that helped. And it helped that we had a team then that we felt were comfortable in going out and doing facilitation. It was something that we were all very comfortable with, so that it was another step as part of the key of success. So when we looked at it, we thought there were a few different areas we wanted to target. The first, obviously, was to get support at the front line, because the front line is where incidents, events, and positive events, not negative, as Siobhan said, start to happen and are recognised. And they're the key moments where you can get the AAR team brought together quickly, but it relies on people at the front line to know what AAR is about. So we targeted the front line, but also we wanted corporate support. So we went to the CEO and ensured that we had the executive management in the hospital also as key stakeholders in making this a success. And our hospital executive group is comprised as well of all the clinical directors in all the clinical areas. So that brought the residents home that this was something we as an organisation were embracing. And then, of course, our external partners were our colleagues in the HSE as Weaving a Voluntary Hospital and the RCSI, because the training was what the underpinning foundation of it was. So all those supports helped to get us on the road and get us started. The other thing we did was ensure that we got our product placement. We thought supermarkets that placed our products carefully are a key to success. So we brought back that into the hospital, and we looked at getting it up on the internet homepage. So when you went into the homepage, it flags across the internet on a regular basis. And we kept that up for about 2 months, so it was there. So people had no choice but to recognise it and see it. We then created all the resources that were available to us as facilitators, and we put them in a place that was easy to find on the internet. So anybody that came across the internet in the hospital without having their own logins could see who the team were, where to find us, and what the different tools available to us were, and how to contact us, so that if you didn't know who's who in the hospital, you had a way of accessing the information. And again, it was about bringing it back, reminding people, and that consistency of message is that we were there and we were reachable at close contact. So the different things that we worked on was getting it socialised before we went out there and being available. And we used the first month when we underwent our own training as being the socialising aspect of it, so that we found we came back to the organisation, we spoke about it, it was something that people understood. We also did up the posters with the 4 simple questions, and we laminated them and put them in every ward in the organisation, again as a key reminder to staff that where to find us and what we was about. So we used all the different mechanisms for getting it into the organisation so that it wasn't associated with safety events or events or outcomes, that it was a time for recognising when it worked well. How we started that process was our ED consultant used it at the end of every shift to look at how the day went. So it was a quick debrief with all her team, what went well today, what happened that didn't, and she kept then mental notes of things where they could make improvements at the end of shifts, and that would have the bigger knock-on for the wider ED team. And that proved to be hugely, hugely successful, because it wasn't on the backdrop of something going wrong, it was on the backdrop of improvement and QI being part of every shift and every opportunity. And that went really, really well. So they were the first key points that worked really well from the ED perspective. She also looked at the opportunities when there were traumas coming in and where shifts went a little bit pear-shaped, as they do for all of us when we work at the front line, and how to capture the key learning immediately at the point of event before everybody scatters. And that again is key, because when I do safety reviews, I find afterwards that the time lapse between the event and meeting with the staff is the time when staff lose confidence, they lose, I suppose, their own ability to perform effectively, and it allows creep to come into situations where you can avoid it by having an after-action review. So this was something, as all facilitators, we replicated as soon as we became aware of events. With the invite of the leaders within the areas, we got in as quickly as we could, and it was a point of reassurance and assurance to staff that this is not about blame, it's about trying to uncover areas for improvement. And it created a safe zone for people to feel they could talk confidently. So this was something, again, that worked really, really well. For myself, within my own domain, I suppose I've used it in various situations. Some are very positive. We use it every Friday within our own QSI team, where we meet for safety huddles every day at 2 o'clock. Friday is reserved for an after-action review, and it's for everyone on the team to look at, did something happen this week that you didn't plan, predict, or expect to happen? And it's a great opportunity for us to do our QI within our own team. And it's a reminder again that it's something we live, breathe, and we work with on a regular basis, and it keeps us on our toes. One thing we used with that, it's a good example, is when the cervical check became a national agenda item across the country. It is something that came into our organisation that we didn't anticipate, didn't plan for, and really was not connected with any one patient, but it was something where queries from the public came in right across the organisation, and the organisation was not in a state of preparedness down at CNS's level and consultants. And we did an after-action review where we brought the entire team together, and it involved about 35 people, and it proved to be hugely, hugely successful. Again, where people that normally wouldn't be in an environment where their opinion might be asked, found they were able to share key learning and bring the teams together. And we were able to capture that learning, and in other future events that may happen, we now have a framework that will help support us through it, even though the players may be different. And that was really, really useful. So when we do them with the view that it's quick, it's safe, it's secure. Some issues we won't address, and we use what's called a car park, and they're for the issues that are not central to the topic at hand, but there's something that are valid, brought up by the people involved, and we address them outside the after-action review. The other key area that we've now moved into is discharge planning. We have a collaboration with the community where we have an assistant director of nursing in the community who's also trained up. So we work collaboratively with her, and what that's happening is it's helping to break down the barriers and the walls between hospital and community so that we can work between our two facilities, being acute and primary sector, and we can help to improve discharge planning. And this is directly improving patient care because we're co-working and now creating an environment where there is a network and a collaboration that wasn't there previously. And this is really, really reducing the gaps for patients and proving to be hugely successful. And again, for our community colleagues, from their perspective, they find they have more support because they now have a network within the hospital that didn't previously exist. And that's been hugely successful. So overall, what works well? Have a champion. You must have a champion, because if you don't have a champion to keep it going and keep it live, it will begin to become a little bit off centre stage. So that for us is key. Breaking it down in a hospital as big as ours, you couldn't take on the entire organisation in one go. So by having our team of facilitators, we triangulated the hospital and had key areas of interest and focus, and that really, really, really helped. The laminated posters was something that was the visual reminder for everybody that was something that was out there and is part of the organisation. And then recharging. And recharging is where we as facilitators regroup maybe once every 6 to 8 weeks, and we say, well, what's going on in your life? We have a coffee. We troubleshoot where we come across issues that we may not each individually have addressed before, and that's helping to build our own skills and facilitation. So really, it's about success, and it's about sharing the wins and keeping the momentum going, and that's what has helped us.
Una, thank you so much. We'll hand you over now to Anya. So thank you, Anya.
Great. Thank you, Maureen, and thank you very much, Una. I'm Anya Klein. I'm the Quality and Safety Lead in the CHO in Dublin North City and County, which is north of the river here. And what I'm going to talk about, I'm new to this AAR, so it's about my experience of participating on the course and how our area, our community area, is supporting training, and then how to date we've applied AAR within the community services. And the community services cover a range of services within acute and community mental health and CAMS and primary care, addiction and social inclusion, and social care, both older person services and disability services. So there's quite a big range of services that we're working with. I'm very fortunate. My experience of training, I had the opportunity to be an observer at day one of the training in January 2018. At that stage, it wasn't community teams that were training, it was for the acute sector, but it gave me a great taster. I've worked as a quality and patient safety advisor over the last few years, so I did have previous experience of system analysis training for serious incident reviews. So I suppose that the training was like unthinking, and because up to that we had very much one size fits all for incident management. So I was curious about this new and alternative approach, enticed by the simplicity of the AAR, but I had questions about how it would work for incident reviews, and really wondering, could it really be as simple as putting an IKEA chair together as it said on the leaflet? So that's where I started out. And as I said, I went representing the area so I could bring that information back to senior management and to my colleagues. The training, I was very impressed both on that observation day and then when I did get an opportunity to participate. The organisation and professional delivery of the course in RCSI was really, really good. What is incorporated into it is a challenging but very worthwhile experience of role play with professional actors. I'm not saying that to put anyone off, I say go with it, just do it, but it was really, really well done. And it really was a privilege to have the learning opportunity to participate in RCSI. Very, very positive experience, and I think it's a really good way to reward staff who work hard in our health services to give them the quality of the learning experience that they get on that course. So I was enthusiastic and I wanted all of my team. We're a new developing team. We have 4 advisors and a health and safety advisor, and I really wanted them to get trained so that they could take a lead in their various areas of responsibility. But what is important, and Una had emphasised that as well in the hospital, is the support of the senior management and in our case the chief officer as well. It has to have that governance. So it's not just individuals going off doing training and it's not happening in a vacuum, but that there is a plan for developing it. So we started our training in September. One of the positives out of the training as well is because we went as the quality and patient safety team, it was really good for team building. There was a balance of fun and seriousness on the course, which I think really helped in the learning. And just for anyone in the community services who's thinking about what the commitment is, it's like one full day and then about 6 weeks later there's a half-day follow-up. But you do have to do your homework in between, putting the learning into action. So that involves just carrying out an AAR meeting, and as they recommended on the course, we worked in pairs, because I think that really did help for support and for mutual feedback. And I suppose what I haven't written there, they did say start with positives, start with things that are easy. Now, one of the things that myself and one of my colleagues did, and I've used this example, we use this for our homework. This is how we've used it, and it's related to incident management, and that's why I've brought it as an example. But we facilitated a reflective meeting with senior managers following the death of a service user in the community. Unfortunately, we do have many unexpected deaths in the community, and some of them, as in this case, can be explained. So there wasn't a need to go further with an incident review, but it did raise that the focus on the governance and responsibilities when more than one agency is involved in the care of a service user. And it was very, very helpful because it steered a constructive conversation. It wasn't about blame, or it wasn't about what you should have done or anything, and it was very much focused on the learnings and the actions arising. So it wasn't an incident review, but I think it was a valuable contribution to the overall learning cycle and the parts of the incident management that maybe get overlooked, that there's so much energy goes into doing the incident review, that the reflective part wasn't to date getting the same attention. So that was very, very helpful. Then after having had the course, we did apply it using it as part of the incident management framework, using it as a moderate incident review in acute mental health service. And this also went very well. And I think what did make it go well is that there was a formal review pathway in keeping with the incident management framework. In other words, you know, this incident occurred, it was obviously reported, there was a safety incident management team decision-making process, decided that it needed a concise review, terms of reference were drawn up. One thing that we actually, in this case, we did a good chronology, and maybe in this particular case, it did help the facilitators. We knew the facts. While I know often the facilitation, there's an emphasis on good facilitation skills. I'm not saying that didn't work on the day, but I think maybe we felt more confident. We knew going into it that we knew the facts, and we had a good chronology done in advance. But also taking the good practices from incident management and system analysis even, was that we sent out formal invitations with time frames agreed, a draft report was then sent out to participants for factual accuracy. So I would say that we combined the due processes and the procedures from system analysis, or maybe we combined the learning that we had and experience we had from that to make it work. And that we had one person as a facilitator and one as a scribe, again, working in pairs. And then I think what was also encouraging was the feedback from participants. They were positive. It took 1 hour out of their busy working day. They liked being in a circle versus interviewed in front of a desk. Other staff that had gone through interviews before, much shorter process than a system analysis. And the outcome, like there were practical actions that came from the staff themselves. It wasn't taken away and experts or objective people giving them what they thought they said. It was they came up with the actions. One thing I haven't written there, but I think it's important also to say, is that it was also an opportunity for what went well, the positive learning, and even individual feedback to each other, the dynamic within the group, that individual staff could give positive feedback to other staff. And at the end, a 4-page report which had all the succinct learning and actions arising out of it, including the good points. So other examples where we've used it to date, just bearing in mind we're at a very early stage, you know, since September 2018, we're still only putting it into practice. So other things that worked well that we've done to date is like a heating system broke down in one of our residential units, and we did an AAR. In one of the other residential units, staff had a very stressful weekend, very unexpected events, and again, staff debriefing really, really helped using the AAR. And we continue, I suppose, at the moment where we're at, we're just continuing with encouraging frontline staff to get trained, because as Una has said in St. James's, they have a range of different disciplines trained, so the potential for mixing different people in different backgrounds. So therefore, we're at the stage of encouraging clinical people to go on the course. And to date, we've had a director of nursing who's gone, a couple of aid-ons, one from mental health, one from older person services, a service manager, and our health and safety advisor as well. So thank you very much. That's my contribution of where we're at this point in time with AAR in our community services. Thank you.
Thank you so much, Anya. And thank you to the large group online listening to us, and thank you for bearing with us. We had a few little technological glitches. We're all learning, so there's PDSAs at work here as we're going. So just to really summarise, I think, some of the big learnings from listening to Siobhan, Anya and Una, and of course Una is from St. James's. Apologies, Una. It's to give you a new job. So, you know, there's fabulous wisdom, I think, when you listen to the many different practical uses of AAR in terms of, you know, having your corporate support, having your training and a team of facilitators, engaging with your frontline, thinking of product management, thinking about socialization, thinking about having your champions, working in pairs, having visible reminders across your system and keeping it to a short time scale. Combining the learning from systems analysis with your approach to AAR, and it all fitting within the framework of incident management. But I think what you've shared for us really eloquently is the broad application of AAR beyond incident and reviews in terms of debriefing after a critical event, in terms of learning after a workshop or an event. So there's many, many, many different ways that it can be used.
Sure, we've heard it being used in the hospital setting and in the community setting, but it's also being used in the HSE at a corporate level.
That's fantastic. That's fantastic. Very well made. I think to remind everybody, Siobhan mentioned the link to the resources that are on the QAVD website, so please look for those. They will be in the slides. The slides from the presentation takes you to all of the links. The lovely piece is the article that Siobhan mentioned, which is Life in the Slow Lane, from Professor Aidan Halligan, who, as we know, sadly is no longer with us. But I think that's really a very good start for some reading in terms of a very practical use.
And you can get it on Google.
And you can get it on Google. So just put in Life in the Slow Lane, and it'll pop up for you. I have a question, if you don't mind, as we're going by. We just keep, if anybody has questions, Naomi will keep us online. But while we're watching for the questions, you know, we've all thought about systems analysis for many years, and Anya, you mentioned having a fear about stepping outside of systems analysis to take on an AAR approach as appropriate. Can you share with us how you tempered those fears a little bit, maybe?
I suppose what I put up there on the slide, that there are, there was still very good due process that we had learned and used in system analysis. As I said, the fact that it was, the decision-making process from the safety incident management team. Also, a lot of I did introduce a formality that is in system analysis, i.e. formal invites, giving people dates. We will get back to you and you will have an opportunity to input into the report, even though it's only very short, 4 pages, to ensure that it reflected what they said.
I think it's important that this is a framework, so services are able to contextualise it. But I think even if after action review is perceived as a little bit more informal than systems analysis, it doesn't affect the due process, because that is the framework. And even if you write a 2-page report, the report is disseminated to all the participants, so they have that opportunity to provide feedback. And that's if it's done as an incident review. It's not necessary, as Una was saying, if an ED consultant is using it at the end of a shift to write a report. So there's all sorts of opportunities to use it. So the report, there is a template for the report on our website as well. And that gives you the structure to follow, and it is a more informal report, but it still can follow the due process.
Thanks, Siobhan.
And just to say, like, there were recommendations, because that was an incident review. They will also be monitored through the governance structure of your Quality and Safety Committee. You know, they're all contributing to the overall learning from incident reviews.
Great. Thank you very much. Una, would you like to share anything further in terms of your personal reflections on?
I think the one thing I would say is that while incident management will always be somewhere in the background when you're considering going out AAR, a lot of it is about is normalising it and making staff feel it was another tool for them to use for all sorts of scenarios. Like, we would use them at the end of conferences, study days, and getting all grades of staff to feel comfortable around the discussion of those 4 questions, because we feel that if we involve more of the team in the true MDT process, it gives everybody equal voice around the table, and that's really key. Everybody is an equal participant when we're doing an AAR, and there's a facilitator, but good facilitation is important because it does need to be held around the framework, and good facilitation helps that process. Otherwise, it just becomes a debrief. So I think you do need the training to be able to have good facilitation.
So don't be fooled by the simplicity of the 4 questions.
Yes, and that's all coming with the training, because again, as Oni says, the RCSI training, it's phenomenally strong, even though you don't feel it at the time. You walk away with skills that you might have thought you already had. The secret is the simplicity with the facilitation.
Thank you, Una, for sharing that. And I think, you know, that little subtle sentence that you mentioned there is that, you know, there's no hierarchy in age or in AARs. Everyone is an equal participant, I think, is part of its little magic. Okay, great. I could go, are you going to say something on this?
No, just to reinforce that.
We have a question from Catherine Hogan. Thank you, Catherine. And the question is, have any of the panel involved a patient or family in an AAR yet? Or maybe that's something for thinking about for the future.
I know that I've been asked that myself within our own organisation, and no is the truthful answer. We have considered it, but we're mindful of bringing a family in. If you're bringing a family in, it's usually maybe because there's been an event. And sometimes staff are not ready to meet a patient at the time you'd normally consider doing an AAR. It's something we've parked, it's something we're considering, but it's how to do it, being mindful of not doing further harm to a family or the staff, because it's a healing process, it's a process of uncovering key learning, quick learning, and sometimes bringing a patient in at that early stage may not always work. Certainly it's something, though, that we're keeping in our space and being mindful of it, to see when there are good opportunities when you can include them.
But there is no reason not to give the report, to share the report with families.
And perhaps, you know, as an early start in learning from it is including patients in AARs that are not around incidents.
Exactly,
You know, as a way of testing and gaining comfort in doing it.
But certainly the framework helps for meetings with families as well. You know, using, not the incident management framework, the framework of after action review. Using those kind of questions to structure meetings is very helpful.
Great. And certainly I have used AAR in terms of quality improvement work, where patients would have been involved in the quality improvement work and would have been present for the AAR. So that's another way, you know, if they're a member of a multidisciplinary team doing an improvement project, that patients participate in the AAR around the improvement project, because it's a great way of just standing back in your improvement work to see where you are. So at seminal stages in the improvement work, if you've been holding a workshop or a facilitated session, or you've been testing a particular tool, you know, using AAR to really see where you are, it can be really useful. Any other last minute questions to anybody out online? If you have any questions, this is the last piece for just to remind you that the slide set will be on a QI Talk Time webpage. We are recorded the whole session, so at your leisure you can listen back to it, or you can recommend it to your friends and colleagues who maybe weren't able to participate today. So I think I'll just take a pause to thank Naomi, who's been helping us with the technical work, to thank Siobhan, Anya and Una for sharing so generously with us the whole approach and your real-world experiences in a very varied group of settings in using it, in community, in mental health services, in care of the older person services, in projects, in cervical screening, in acute hospitals, to name but a few. And just to remind you, our next QI Talk Time is on Tuesday, 2 weeks' time. And Naomi, with those of you who are on Twitter, watch out for the tweets about it. So it's Tuesday, March the 5th. From 1 to 2, and we will be sharing from teams across a wide group of services focusing on frailty and caring for frail older people. So thank you to all the QI Talk Timers, and we're wishing our normal facilitator, Roisin, a lovely holiday. So it's Maureen Flynn who's been with you, speaking on Roisin's behalf until she returns. So thank you, everybody, and enjoy the rest of your lunch break.